of Salam Media with me, Mariam Mia, and we are on Inspired Afternoons. And now we're going to get educated with our healthcare and medical focus, and who was a regular throughout our journey of Ramadan. And we've reached now the 10 days, and he's still smiling. Alhamdulillah, maybe he's used to fasting now. And that is Professor Shahed Omar. He's a critical care specialist and chemical pathologist at Path 24. And on the back of discussing the cholesterol last week, and he put a bit of a damper because we all feel a bit guilty when we're indulging now in one of those fried, delectable treats for iftar. But nonetheless, this is all for our health and benefit and for our wellness. And so we thank him for making us aware of this. And that is why we decided now, let's continue the segment because let's focus today's show focus on chest pain and heart attacks. I think it's important to understand uh, why chest pain. So understand that symptom when you have chest pain. What is it saying? What is your body telling you when you're having uh, a chest pain? And do you neglect it, or as soon as you feel the pain in your chest, do you go to GP immediately, or do you go to the emergency room, or at what intensity do you then decide I need to have this and I need to go to the hospital? So unpacking all this is, let's welcome Assalamu alaikum, Professor Shahid.
Walaikum salam, Mariam. Jazakallah for having me on the show again. And assalamu
Yes.
alaikum to all our
So
viewers.
now this is also up your alley because you normally see people after they've had a cardiac arrest or they're sitting in ICU. And I mean, this is when we didn't take those statins or didn't go at 35, 30 for our cholesterol test and things like that. Then you see people when it was like now we have to do, so it wasn't preventative, but now we have to sort out major issues. So let's go on the chest pain
Okay, so
and heart
all right,
attacks.
so let's start there. I think chest pain is a good place to start because it's one of the most common reasons for people to seek help at an emergency department, both worldwide and back home here in South Africa as well. In fact, probably 5 to 10% of ED visits are actually for chest pain, and this is especially true, in our urban areas. So, in the cities. So it's really important, and it is important for several reasons because there's a diagnostic challenge. Firstly, there's many causes for chest pain, and just to pick up from last week, we had all those risk factors that we spoke about, abnormal cholesterol and hypertension and so on. So, somebody who has those risk factors and then develops chest pain, certainly you need to seek help. And remember that chest pain, the causes could vary. So it could vary from what we're really worried about, the heart attack or acute coronary syndrome that we talk about. But it also could be other things. It could be, for example, musculoskeletal pain, or it could be a reflux pain, or it could be a pneumonia, or it could be panic attack. So there's so many different possibilities that it presents a challenge. So it's important to actually seek help. What we also want people to know is that when it comes to the heart, every minute counts. I'm going to say this over and over. You're going to hear this adage, but we say time is muscle. So this is very important. Okay. And, although only maybe 10 or 20% of patients that present with chest pain will actually have an acute coronary syndrome, okay, we need to identify these very quickly. And you can see that there's a whole host of other causes, and we need to find a way to pick these patients out so they could actually get treated quickly and appropriately for the best possible outcome.
Well, what type of a pain?
So,
A piercing pain, like a muscle stuff pain, or what would you feel when you're getting this in what intensity should be a cause of concern?
okay, so good. So remember, we must always take it in context first. So the risk profile. We talked about all the risk factors and the age, about 40, and and so on. But the type of pain is usually a crushing pain. It's described as a crushing pain, okay, and it radiates to the arm, the left arm, or the jaw, okay. So it's important that those kind of pains actually are taken seriously, especially in the group of patients when you have risk factors. So that's important. But I also want to mention that there are groups where you won't have this typical chest pain, and women may specifically not have this typical type of chest pain. So they could just have simply nausea or they have back pain, and we wouldn't know. So they often go undiagnosed. And another group that's also at high risk that may have atypical chest pain are diabetics. They may have silent chest pain. We call it silent chest pain. So certainly they are also one group. Okay, that may not present typically. Okay.
Okay, so ultimately, the causes of this acute coronary syndrome that you're referring to, let's go to the slide and then you can just explain to us on the
Yes.
slide.
Okay, great. And I don't know if you remember from last week, we spoke about, the dyslipidemias, and when we have too much
Mhm.
fat in our diet and poor diets, and the excess cholesterol and fats, these lipids, get carried away to the blood vessels and they get deposited in the walls of the blood vessels. So now what happens is that these fatty streaks or fatty plaques, they have an inflammatory component and they can actually rupture. And when they rupture, okay, they incite or they trigger the formation of a blood clot. Now you can see in that picture, once that blood clot forms, that the little picture that looks like a bunch of grapes, then you can
Mhm.
see that the flow that goes beyond that point is reduced. Okay, so now this puts the muscle, the heart muscle, at risk of not getting oxygen and nutrients. And then this can cause the heart muscle to die, or what we would call myonecrosis.
So
Right.
I need to ask you something. When it ruptures, do you feel a pain or it can just rupture and you won't know?
Yeah, so when it ruptures and when you starved of blood supply to your muscle, that's when you start feeling the pain. So often
So
this is a
that's
process. Yes,
okay. No, it's interesting because you know now more or less what's happening, because sometimes you might experience internal bleeding from somewhere, but you might not feel pain or you might not know. But you're saying thus, if it ruptures, it will. I guess then there's a whole different reaction in the body in terms of what the body does, and one of the things is you will then feel a pain in your chest.
exactly. So as soon as this obstruction becomes significant enough to block flow to your muscle, and the muscle is starved of oxygen, the pain will come. So it's very important to seek help as soon as possible, because what we don't want is we don't want irreversible injury to the muscle to occur. We don't want this flow to stop and the muscle to die. Okay, and so we want to get this treated as fast as possible. So that's why we say time is muscle. Right? I'm going to say this a lot. You'll hear it a few times. Time is muscle, and maybe just to get people to remember this.
Okay, so now what is the term acute coronary syndrome? So if you can just tell us what, so if somebody says they have acute coronary
So,
syndrome, what what are we talking about?
okay, perfect.
I'm
So
just going
this
to ask
is
you to
real.
put on that slide. Uh,
Yes, put on that slide.
let's go
Yeah,
there.
that's the one.
That's the one,
Okay,
right?
perfect. So really, this is really what we're chasing after when we have chest pain. This is what we want to find and treat early, and we've got to try and find these patients. So that's the real challenge for us. Okay, but acute coronary syndrome is an umbrella term. So what it refers to is a few conditions where the blood flow to the heart muscle is suddenly reduced, like we saw. Okay, so and this is usually caused by this plaque rupture, but there are three main terms that we use as medical professionals. Okay, one is called STEMI. Okay, it's a type of heart attack or myocardial infarction. The other is called NSTEMI on the left in the blue picture. and that's called a non-ST elevation MI or myocardial infarction. And then we also have something called unstable angina. Now, you can see that if we look on the left, we have what we call anstemy, and you can see that what happens is that the blood vessel is partially occluded. Okay, and if you compare it to the STEMI on the right, there the clot is so big that the blood vessel is now almost completely occluded or completely occluded. Now, you can imagine that the healthcare team that's looking after you, they can't see this when you present to the doctor's rooms or the emergency room. They can't see this. So what they need to do an ECG very quickly. Okay. And this ECG will give them clues to whether it's an NSTEMI or a STEMI. Okay. And this is important because in an NSTEMI, the ECG has a specific pattern. We call it ST depression. Okay. And in the STEMI, there's ST elevation. So the changes are slightly different, but they actually tell us which condition we're probably dealing with. And why this is important is because the STEMIs, they need to be treated very quickly. Within 90 minutes, they need to be unblocked. So they need very rapid correction. Okay, otherwise you lose a lot of heart muscle. Okay, and the end STEMIs, they also need to be admitted because they can progress as well, and they also need to be evaluated quickly, but not as quickly. Now, what the ECG you can see helps us here as an important clinical tool or diagnostic tool. But in addition to that, what we have is a second test. This time it's a laboratory test that we need, and this is called the troponin test, or what we call the high sensitivity troponin test.
Okay, I'm just
And
going to
this
ask,
is,
sorry, Prof, I'm just going to ask Abdul Salam to put on the slide of the
no, no,
troponin test.
leave this slide.
All right,
Okay,
yes,
yeah, that's fine. Yeah. All right, so this troponin test, if this is positive, then we know that the heart muscle has been damaged and there's a leakage. And if it has the ECG pattern on the left, then we call it an NSTEMI, and then these patients get admitted and they get a certain protocol of treatment. But if they have those ECG changes, but they don't have the troponin positive test, then we call this unstable angina. Now, these patients are also at risk, so they also get admitted and they get monitored and treated, but in a different pattern. So the important thing is that the acute coronary syndrome consists of these three conditions: the STEMI, the NSTEMI, and the unstable angina. So this is the umbrella term for all three of them, and all three of them need to be diagnosed because all three of them need urgent admissions. And why we need to differentiate between them is because their treatment strategies differ somewhat, especially from a time point of view. And the other thing is, remember that while the STEMIs are the most dangerous ones immediately, this is a continuum. So the unstable anginas and the NSTEMIs, they can progress to STEMIs, and which is why that we need to catch all of them. We can't just say, oh, we only worried about the STEMIs and the ECG will give us the answer and we don't have to worry about the others. We need the others because they can progress and they also need to be managed urgently. So they all three will require hospital admission. Okay, and they all three also then require a risk categorization to look at what um, their their outcomes are likely to be. So we want to then categorize them into risks. But that the doctor does with a whole lot of more information.
Okay, so I just want to ask you, if somebody's have severe chest pains and they just a family member is presenting with severe chest pains and you feel you need to call in ambulance, and then often while you're waiting you feel helpless, is there any medication or anything that you can offer the patient to take while you're waiting for an ambulance?
Yes. Okay. Well, that's a very good question, Madam. So, and this is very important for us to actually take note of because if the patient's not allergic to aspirin, okay, then we should give them an aspirin. So, and we need to take a full dose aspirin. You know, the 300 milligrams or the 325 milligram, the full tablet of aspirin. Okay. And even if you're already on, you're taking half a aspirin a day or whatever it is, you still take the full one. Okay. because this medicine, and what we want people to do is, there's this chewy tablet. If we got those get absorbed faster. But whatever you have, you take it a full tablet, because this helps start breaking down the clot. Okay, and this it gives you an added advantage. So while you're waiting for an ambulance to get you to hospital, you already have some medication starting to work. All right, so this is important. So if you're not allergic, then obviously then this is something that you should do. So that's a very good question, and I think that's important that people are
So
aware that they
aspirin
can
should
do
be
something.
part of your your self medication at home in your medicine cupboard. Always keep aspirin there. So I mean, you'd advise to always have make sure you have aspirin.
That's right. That's right. And know that if you're allergic or not allergic to it, because obviously what we don't want is, if you know you're allergic to it, then obviously you'll have to wait to get to the hospital, because then there are alternative drugs that people would use.
Okay.
But
So
yeah,
last question for today: how exactly do cardiologists open up the artery?
okay. All right. So yeah. So this is a nice question. We should get a cardiologist to join us here. You can tell us exactly how it's done. But to give you just an overall view. So from the emergency room, and this is quite important also, because one of the things the paramedics will do when they assess you, when they arrive at your house. So they will then, depending on your severity and risk profile, they will then take you to an appropriate hospital that has what we call a cardiac catheterization lab. So you need a cath lab, so that's where a cardiologist performs. So what you don't, ideally you go straight to a hospital that has one of those, because if you do have a STEMI, then you've got 90 minutes to get to that lab, and the cardiologist needs to unblock the vessel. Okay, so that's the first thing that's important in terms of the pre-hospital transport, that you go to the right facility. And we're fortunate here in Johannesburg. We've got lots of different hospitals with cath labs and lots of well-trained cardiologists, especially within our community. So we've got some really very good heart specialists.
So again, time is muscle.
Time is muscle. Okay, and then obviously we now use the cardiologists now use the artery on the wrist. Before, they used to use the artery on the groin to get access to the coronary vessels, and then obviously they use a tiny balloon to unblock it, and they can put a stent to keep it open. And then obviously you'll be on medication to
So
keep.
basically, the stent is something just to keep it apart.
That's it, to keep it from blocking up again.
Okay. And then and then because sometimes they'll say they put in a stent or couple of stents, so it just depends
Yes.
how many arteries are blocked.
Exactly. So when they do the angiogram, they'll be able to assess all the coronary vessels, and then they'll decide, which vessels need to be stented and which not. And sometimes the best course of action will not be stenting, and they'll say there's too many vessels, they're too complicated, and a bypass will be required. But that's become very rare now, because most of our heart attacks are picked up early, and we've got good treatment, and uh, you know, um, uh, one one or two vessels get stented, and that works well. But in on the odd occasion, they're very poorly controlled some disease, and then multiple vessels, and then they would require a cardiothoracic surgeon. But that's a rare event. But still, you need this process. Otherwise, you don't know that that's required.
Okay, so going back, let's just summarize this. Chest pains, number one, get it if it's mild. GP, I'm sure most of the GPs, I know some of them have the ECG machines at their practice. So go to a GP that has a ECG machine, because that will be just to check if everything's okay, or they can tell you, oh, you had a mild attack, or the readings are not there and there's cause for concern, and they'll probably then recommend you to go to a cardiologist. And all the while, we need to be cognizant that time is muscle, time is muscle. So just do that. But if somebody's presenting with severe chest pains, straight to the emergency or call the ambulance. And if you're not allergic to aspirin, give them an aspirin, or somebody if you're taking something like Ecotrin,
Yes. So that's what I said. If you regular maintenance aspirin, that's usually 75 milligrams or 100 milligrams. And even if you're on that, you take this big dose as soon as you have that bad chest pain. So even if you're on that, because that's usually a small dose, so we then recommend, what's recommended by the guidelines is the 325 milligram, the big dose, or the 300, depending on what you have at home. And just one other thing is that, so sometimes you end up going to your GP, and they'll do an ECG, and if they're uncertain, even while they're sending you to a hospital, they can already have the blood test started and sent off. So by the time you get there, because there are certain timelines we have. When you get to the emergency room, we have a 10-minute window to get the ECG, and then there's a 60-minute window to get your troponin. And in nowadays, we've got some really good emergency room laboratories that give us these results within 30 minutes. So the troponin test can come within 30 minutes. So within 30 minutes, of getting there, you can actually know exactly if you've got one of these three coronary syndromes. And these tests, these troponin tests, are also very important because we can repeat them at 1 hour, and in certain conditions, we can actually say, okay, we can rule it in or rule it out. So it helps us both ways. So it's a
Okay.
very useful tool.
So, Shukar, for this, I think this is vital for all of us. It's very, very educating and empowering to take charge of our health like this, to understand what happens. Dull chest pain or mild chest pain, GP, this, so we know it, and we all the while, as you've mentioned, today we have very, very good facilities, resources, treatments, and um, experienced cardiologists and GPs, along with diagnostic tools that can detect a heart attack or early heart attack, so preventing before you get, like you say, bypass. Have now the amount of bypass we've performed have been reduced drastically because there are early warning signs, and you're catching these heart attacks before they warrant a major bypass and major surgery.
Perfect. All
So
right.
thanks so
Excellent.
much for this.
Okay.
It's been really, really educating, and inshallah, hopefully, we can get you on one day in the future after Ramadan to speak about the
Afterwards.
thyroid and the thyroid test, inshallah. But jazakallah to yourself as well as Path Laboratories for making these segments available for all our viewers and our listeners. And remember, these are on YouTube. So if you need to go back and take a listen again, if you forgot, or you need to know this, it's always on a reference. If you just YouTube Salam Media, Path 24, and whether you're doing this one or the cholesterol test or the other ones that we had discussed, or the hemoglobin ones as well, please, they all there as a reference, and we'd like to acknowledge Path 24 Laboratories for making your partner in good health, which is your wealth, for making it available. Jazakallah so much, Shahid, for your time, and we wish you well for the remainder of Ramadan, and we say we wishing you and your family a joyous Eid. Alhamdulillah. Assalamu alaikum.
Wa alaikum salam. Jazakallah for having me. Assalamu alaikum to the viewers.
We're going to go for a break, and then we're talking Ramadan traditions, and we're speaking about something everybody looks forward to on the iftar table, that is samosas. And we've managed to locate, I think, the father of Alim in South Africa, brother or uncle Solly Manjra. So all this after the break.